So a very warm welcome to all of you and a very good evening. Thanks for joining in the second monthly webinar of Indian Society of Colposcopy and Cervical Pathology. And I really appreciate that you are investing your time in being a part of the ISCCP. And with this, for your efforts, we have started one new system which we are going to introduce today, and the details are also available on our website. So your efforts matter. Let me just have a screen show. Yeah, so your efforts matter, your contribution matters. So we want that you should be recognized. So earn credits and be recognized by Indian Society of Colposcopy and Cervical Pathology. In this initiative, we are going to give a credit points for the organization of the public forum, CME, workshops, and any of the academic activities under the banner of Indian Society of Colposcopy and Cervical Pathology, which have been started around 2 decades back by our patrons, Dr. Swaraj Batra and Dr. Vijay Jutshi, and we are continuing with this legacy and introducing this new system so that your contribution will help us a lot to disseminate the information and contribution regarding the ISCCP. So in the public forum, how we are going to give you the credit system, thus to introduce that. In this, we are going to give 2 ISCCP credit points for each public forum you conduct. A minimum of 10 credit points will be required to be eligible for the ISCCP Appreciation Certificate at the ISCCP Annual Conference. The members with the highest number of credit points will receive a plaque and a cash award of rupees 10,000 in Annual Conference of ISCCP. There are few instructions which you can go to website regarding how you have to do this public forum. The important thing that you have to put a banner, which we have formed a prototype banner, which you can obtain from the website. It has been uploaded in our website in the opportunities section. And we are going to reimburse the money for making a banner one time for all of you. And you can mail this information and a bill to secretariat at the rate of isccp.in. Another credits which will be given to any CME conference and the workshop conducted under the banner of ISCCP. For this, individual have to be a member of ISCCP. Permission must be obtained 15 days prior to the event, and send your request and full program schedule so that we can allot according to the program the relevant credit points to you. The certificate should carry a ISCCP logo and the signature of ISCCP President and Secretary. You can do it under the aegis of ISCCP, or you can write down in association with ISCCP, and you have to use a ISCCP logo in banner. The important thing that your contribution will be awarded in the annual conference. The individual earning more than 20 credit points in a year will be recognized at the ISCCP annual conference, and the highest credit point achiever will receive a special award and the recognition. So be there with us and organize your conferences, workshop, and public forum under the banner of ISCCP. Beside these 2 announcements, I'm going to make another announcement regarding the training program. So you can advance your gynecological skill with India's most wanted colposcopic training program, Fellowship in Colposcopy. And this is organized by Indian Society of Colposcopy and Cervical Pathology. This is a hybrid program of 6 months. Intensive training is being given. There are weekly interactive theory classes online. The recording of the classes is provided so that you can revise it. Hands-on training at designated clinical centers, the list of which has been updated on the website. There is you need to maintain a case logbooks. Training in cervical cancer screening methods, colposcopy, how to manage screen positive cases, management of pre-invasion lesion, and mentorship throughout will be given to you all. There will be a final exit exam so that we leave no stone unturned in our training. So take advantage of being an ISCCP member. Apply today for ISCCP membership. To tell you all, we are affiliated to International Federation of Colposcopy and Cervical Pathology. So you can get all these details on our website, that is www.isccp.in. Moreover, all these recordings which we are conducting here online will be available on the website. So you can go to ISCCP Academia section where these recordings are being uploaded every month. Moreover, the access to the journal can also be done at the site. If you want any other information, you can contact us via email, or you have a number of myself, the secretary, joint secretary, treasurer, anyone, you can contact us for any help you want. With this, I take this opportunity to hand back the mic to Monga for further conduct of the session. Thank you all.
Thank you, ma'am, for the welcome address. And I hope everybody will be joining the course of the colposcopy as ma'am has shared with us. And without further ado, I invite our chairpersons to for the next session. Our next first session is CIN2 striking the balance between intervention and observation, for which I invite the chairpersons, Dr. Rupinder Sekho ma'am. Ma'am is Chief Gynec Oncology, Artemis Cancer Center and Hospital, Delhi, New Delhi, and she has many achievements and awards to her name. She'll be joining us as a chairperson. Next, we have with us Dr. Jyoti GS. Ma'am is Professor and Head of the Department, MS Ramaya Medical College, Bengaluru. We welcome you, ma'am. And we also have Professor Dr. Mamta Dagar with us. Ma'am is Professor, Institute Sir Gangaram Hospital, Delhi, with keen interest in preventive gynec oncology and certified robotic surgery training. We welcome you, ma'am. And our speaker for the first session, we have with us Professor Nisha Singh, ma'am, Professor and Head of the Department of Gynec Oncology, King George Medical University, Lucknow. We welcome you, ma'am, and I invite you to share your screen and start the first session.
Yeah, thank you so much. And can you see my slide?
No.
Not yet, ma'am.
Not yet, ma'am.
Okay, just a second. I don't know what they are asking for. What is it? Can you hear and see me now?
I can
can
hear and see you,
and
Dr.
hear you.
Nisha, but your slides are not visible.
Yeah.
Wait, I actually cannot. Just a minute.
You want to send the presentation so that we can put it up?
I don't know what.
Is it on the desktop?
Is it opening on your?
No, it is opening. Everything is fine. I have lost, what I was.
Bottom
the way-
screen पे share button देखिए डॉक्टर
नहीं,
निशा.
वो सब ठीक है.
So
Wait.
these are technical glitches.
I'm
I
just
think
doing it.
ma'am will be able to get through. Meanwhile, I can have my chairperson. They can just give their insights into this.
Yeah. So, is Dr. Rupinder here?
Ma'am,
Rupinder, ma'am?
I didn't see her. Maybe now
Will
I'll
be
check
joining
again.
soon. The topic of today's first presentation by Professor Dr. Nisha Singh is very aptly chosen. CIN2, whether we should be observing or doing interventions. So she will probably will take us through all the guidelines and what we should be doing, because CIN2 is such a dilemma for us. What exactly we shall be doing? We are somewhere standing in between CIN3 and CIN1, but now with so much of advances We have with us, like there has been advancement in the HPV screening, but we have now with us, because of the molecular, advancements, the tools to find out whether this patient is the right patient to be observed or to be undergoing the intervention. So I understand that this is what
Yes. So
Dr. Nisha will be throwing light on. A very good friend of mine, my batchmate. In fact, welcome, Dr. Nisha.
I thank you so much. I'm sending my presentation. I don't know
Yeah,
why
yeah.
for sharing
To
this
send the
screen.
Dr. Impu can share
Yeah, send it
otherwise.
to the, yeah, just a
Yeah,
minute.
she's the
Because
host.
I don't know
And you
why
can
it
even
was.
log out and join again, Dr. Nisha.
Yeah, this is what you do. Meanwhile, you send her and then log out and join.
Mm,
So, Dr. Jyoti,
So I don't have Rimpi's email. I think I'll
You
send
can
to the.
you can send on WhatsApp. We'll
you
open.
can send on WhatsApp.
yeah,
Don't have WhatsApp on this. Can you just speak out your mail if you don't mind, or just put it in the chat box? I'll
Okay,
just do
you just send it at Aruna Nigam 2016.
Okay.
Dr. Jyoti, would you like to give your comments?
Yes.
मैम आई हैव
At the
जस्ट
rate
सेंड यू माय ईमेल
gmail.com.
आईडी
Yeah, yeah, got it.
वो
That's
ईमेल आईडी भेजा है मैम इफ यू वांट टू
हो गया, हो गया. Yes.
As rightly said by Dr. Mamta, see, into certain gray zones are there, and I was very much waiting to hear from Dr. Nisha that regarding which are the special conditions where you just have to observe and not do any intervention. Um, and the type of treatment in CIN2, whether we can still do ablative or whether excision is a must, or and what are the latest developments which will help us in just observing the patient. Conservative treatment is what I am looking forward to from Dr. Nisha.
Thank you so much. I have sent the mail. Is it received?
No, not yet. You have sent on mine, na?
Yeah, Dr. Aruna, yours.
No, not received yet. It's open. Mine is open. In the meantime, what we can do, can we start with the
Panel.
panel and we'll come
It's
back in 30-35 minutes, Dr. Nisha, if it suits you.
just check it once. It's showing in my sent box.
Yeah.
So,
मैम आप मुझे भी भेज दो
आ गया. Okay. Got it.
okay, okay.
Let me just download it.
Good.
मैम वो लखनऊ से
Actually,
आना था ना
Yeah, okay.
No, actually, it has happened for the first time. Somehow, for sharing, it was asking lot of passwords. I don't know why, and I tried to give, but everything was in front of me, but it was asking for a lot of passwords. I don't know what needed to be done. Anyway,
Is
so
it
I,
visible now?
yeah, sure.
Yes.
Just put it in
Okay.
the.
Yeah, just I'm going for a slideshow.
So, a very good evening to all of you, and thank you so much for giving me this opportunity. And I realize that with Dr. Aruna having taken up as the president, a lot of new activities are coming up. And so, is that the full screen now?
Yeah.
Everybody can see? Okay. So, the topic that has been given is the CIN2 lesions, striking balance between observation and treatment. Will someone else move the slides, please?
Only I can do, please.
I'm really sorry for that.
No, no.
So, as you all know, cervical intraepithelial neoplasia, it is actually a spectrum of precancerous changes in the cervical epithelial cells, ranging from mild dysplasia to severe, and later on it can convert to invasive cancer. And we all know that HPV infection is the starting point, and it's only when there is persistence of this infection, it leads to precancer, which can later turn into invasive cancer. And these progressive changes need to be understood, and there comes, where comes CIN2, we need to understand that, and then its management. Next, please. So as you can see this picture, it is, I think, a number of times in number of presentations, but it's really a beautiful picture. The normal epithelium, and then how there is a HPV infection affecting isolated cells, and those cells can be seen as coilocytes. And later, when it leads to dysplastic changes in those cells, and if it is the lower one third involved, we call it CIN1. If the middle third of the epithelium is also involved, we call it CIN2. When the whole thickness of the epithelium is involved, we call it CIN3. And when the basement membrane is invaded, we call it cervical cancer. So this is how it progresses. And then in all these progressive changes, there is the risk of developing cancer goes on increasing. Like for CIN1, it may be just 1%, with CIN2 about 5%, and 3 about 12%. And simultaneously, the rate of regression goes on decreasing. From CIN1, these are just rough rounded up figures. About 70% of CIN1 would regress, about
ஃபுல் டைம்
50%
பார்க்கறதெல்லாம் கொஞ்சம் இப்போதைக்கு கஷ்டம் தான்.
CIN2 would
ஒரு
regress.
யார்ட்டையாவது பேசி அந்த மாதிரி சொல்லுங்கிறாரு. பட் நான் வந்து
30%.
Yeah,
இது
I
பண்ண முடியல.
request Dr. Angamal to please kindly mute. Yeah.
While only about 30% of CIN3 would be regressing. And that's why, as the severity of the dysplasia increases, there is a need that we treat. And therefore, by most of the guidelines, it has been that
ஹலோ
CIN2 plus lesions should be treated.
சரி.
Next, please. Now, this is a tabular representation of the various nomenclatures that have changed over time. So, as I told about the natural history, that infection leads to precancer to cancer. If you see the cytology, the Bethesda system, usually when there is only infection, the reports may be NILM, which is no intraepithelial lesion, can be ascus, can be LCIL, the low grade lesions. And then when the precancer actually develops, then on cytology, you will get the HCIL. Cancer, of course, is cancer. But in histology, previously it was the dysplasia nomenclature, which was mild, moderate, and severe, which we correlated with the new nomenclature, that was CIN1, CIN2, CIN3, depending upon the thickness of the epithelium involved. But the latest that we have is the last nomenclature, the lower anogenital system that is there for the nomenclature. And now we have only, next please, only a two-tiered system. And so it is only LCIL and HCIL. So why CIN2 has not been retained? I'm starting from this because this is the newer change, with the residents or the general gynecologists who are attending the webinar should understand that now histologically we say that we should define it, we should just classify it into a low grade and a high grade lesion. This is because CIN2 was mainly a morphological entity without a biological correlate. And there was a lot of heterogeneity histologically. Some cases, when another pathologist would say it is CIN3, or another would say CIN1. So the reproducibility of CIN2 diagnosis has been historically poor, and there is a low inter-observer agreement. And that is why this change has come. And then the change came that if you want to add the biological correlate, if you want to add something which actually prognosticates whether this is going to go towards a high grade lesion, is by doing the immunohistochemistry with P16. So if there is a CIN2 lesion and you have the facility of IHC and you add P16 testing to it, then if P16 is positive, then it indicates that it is an active oncogenic HPV DNA infection, which upgrades the lesion to a high grade lesion. So P16 positive, next please. P16 positive and negative will help us decide whether, that is one important aspect that tells us that whether we should treat it urgently, or we can whether it should be taken as a high grade or as a low grade lesion, and that will affect our management. So that is one aspect if you have the facility. Next please. So now coming to when to treat and how to treat. So these are just the colposcopy pictures that you get when you have a CIN2 lesion, the S2 white area and the Lugol's iodine negative area. Next, please. While in CIN3, it will be much more bigger lesion or more dense, and then the involvement, similarly, the Lugol's iodine. So this is how you'll get, and then you make the diagnosis. So now understand that the diagnosis is both histological, and also on colposcopy findings you can assess and estimate the degree of the lesion based on the various findings. Whenever it is a CIN 2 or 3 or it is a high grade lesion, ideally an immediate treatment is recommended by almost all the guidelines except for few conditions which I will come to later. The young women which are less than 25 years or even if more than 25 but have fertility or actually obstetric outcome concerns, and the pregnant women. These three categories where you have to really think and then treat, or what else can we do, we'll talk about that. And then the second important thing apart from the histological diagnosis is how is the colposcopy. If the colposcopy is satisfactory, lesion is small, both excisional or ablative methods can be used. But if the lesion is big, there is inadequate colposcopy, the transformation zone is type 2 or 3, it's a menopausal woman, it's a recurrent CIN, or previously the margins were positive. In these conditions, it is the excisional methods only because the risk of incomplete treatment or persistence of disease will be higher. Next, please. Next, please. Now, if the margins come positive after the excision, then you follow up with cytology and ECC at about 6 months. And alternately, you can repeat the excision if the endocervical margins are positive. And if the repeat excision is not possible, then only, and or if there is a recurrent CIN2 even after the repeat, then only hysterectomy can be. Now that I have used this term here, next, please. Yeah, so I'll come to that hysterectomy once again. But just showing you the slide that we have from the FOXI guidelines for the management of CIN2 and 3 lesions. So whenever you get this on histology, you review the colposcopy. If it is adequate, you can do LEEP or ablation, I just told, and we'll be talking a little more later. But if it is inadequate, or if the ECC is positive, or if it is a recurrent condition, then definitely a conization is required. Next, please. So as I use the term hysterectomy, I want to really say it all over again that nearly always it is inadvisable for SIN 2 or 3. Why? Because there is no advantage over the local excision. You have the excision procedures available. Follow-up will be required in both. Many times people say that because the patient is non-compliant, will not come back, we've done a hysterectomy. Even if you're doing hysterectomy, you need to follow. And also, in case there is microinvasive disease, then you will not be able to do a complete surgery, and also for the radiotherapy there will be problem. So only indication could be when you are actually doing the surgery hysterectomy for some other indication, which could be a uterine or ovarian pathology, or it is an elderly patient where there is a recurrent disease which we talked about, or if it is adenocarcinoma in situ, where also the cone should be done first and confirmed, and then we should go ahead. Then there are reports that vaginal hysterectomy or LAVH will be preferred if you're doing a if you're doing hysterectomy for a woman who simultaneously has cervical lesion, precancer, because the portio vaginalis of the cervix is better removed in these methods. But that will be decided by a lot of other factors. So follow-up of these treated cases will be by cytology, colposcopy, or combinations of cytology, colposcopy. But we all know HPV test is the best test of cure, and the positivity rate of HPV testing after treatment, it actually falls steeply from 3 months to 12 months. So previously they said 6 months for the test of cure, but now everybody says at 12 months you should do the first test of cure. And then follow up is required, which I said before also, for about 20 years after the treatment. In immunocompromised women, it has to be further, lesser frequency has to be there. Next, please. Oh, sorry, it has to be more frequent. Now, this is just a comparison of the ablative and the excision methods. We know cryotherapy, cold coagulation, laser vaporization, and electrocoagulation by dithermy are the ablative methods, while excision methods are LEEP and needle excision, straight wire excision, or a cold knife conization and laser conization. If you compare among the ablative and the excision, grossly we have said if the lesion size is involving more than 75% of the cervix, if it is a post-cryo recurrence, if it is a lesion extending in the cervical canal, or there are glandular atypical cells, in all these conditions, excision is better than ablation. So ablation should be done in very clean cases where you can see the whole transformation zone, and there are no glandular atypical cells. Cervical curettage is negative, and there is no suspicion of microinvasion. Next, please. So this is just a little more detail about the two methods. I don't know if I have time to spend on this. I'll leave this. Most people know that the ablative methods are basically just destructing the destruction of the tissue, while excision is removal. The main advantage for excision method is that it is both diagnostic therapeutic, because you're getting a tissue which can be assessed histologically, so the diagnosis is confirmed, and also the margin status is known, so you know whether it is a complete one or not. The only problem is the increased chances of preterm delivery, cervical insufficiency, and abortion, which has been reported in some studies. Next, please. When you compare the two ablative methods, that is cryo and thermo, success rates are almost the same, but you know that the duration of therapy in cryotherapy is much more than thermocoagulation. You can have multiple applications in thermocoagulation, which is an advantage, and so a larger lesion can be covered, while with cryotherapy, only the lesion that can be covered by the tip is possible to be treated. Next, please. Comparing LEAP and cold knife conization. Now, cold knife conization is a procedure which will be done under anesthesia, more expertise, some intra-operative and post-op complications may be there, but the technique is particularly useful in specific conditions like type 3 TZ, glandular disease, suspected microinvasion, and repeat treatment. LEAP is a very commonly used procedure. With minimal training, it can be learned and can be used in most of the conditions, and is a very useful technique. Next, please. So the WHO also says that whatever you have, use cryotherapy or LEAP or CKC, at least something has to be used if a diagnosis is made. But if you have everything, then cryo and LEAP will be preferred over CKC. And CKC will be preferred over LEAP only when there is a histologically confirmed AIS. I even told some other important indications. When resources are limited, cryosurgery can be used as a part of screen and treat. Nowadays, thermoablation also. But where facilities allow and everything is available, then an excisional treatment using electrosurgery is better because of the advantages. Now coming to the second aspect, when and how to observe. Next, please. Now, why do we talk about regression? We talk about observation in certain situation because of the appreciable regression rate. And even the ASCCP coming from United States, they even say that CIN 3 plus can be taken as the main clinical endpoint. And there are studies, systematic reviews, and meta-analysis that have shown that the CIN2 managed conservatively, about 50% will regressed, and 32% persisted. Only 18% progressed to CIN3. So with all this background, this regression is particularly more in younger women, younger than 30 years, and most regression will occur within 12 months. So on this background, we can offer observation. Next, please. So the rationale for deferring treatment is the potential risk of adverse obstetric outcome, which have been reported in some studies, that is abortion, premature delivery because of the short length, and incompetence, you can say, and increased risk of preterm delivery that we have said. Next, please. So the term that we use is watchful expectancy. So observation doesn't mean you just leave her and you just keep seeing the patient. So in three conditions, a woman who is less than 25 years has CIN2, a woman who is more than 25, but she's very concerned that because she doesn't have children, that when she will have children, she might have these problems, and a woman who is pregnant currently. In these conditions, you can offer observation, but it is called watchful expectancy because you are very watchful of the changes that can happen during the follow-up. Next, please. So for women who are younger than 25 years, we say that observation is acceptable. Treatment is, of course, preferred. So it's an alternate. Now, during observation, you will include colposcopy and cytology because she is less than 25. So it is cytology and colposcopy, and you do it at 6 months interval. If during surveillance, all cytology results are negative and they are less than ASCETH, and histology is less than CIN2 at 6 months and 12 months, then you can do the subsequent surveillance at 1 year. And once you have an overall surveillance of 2 years and there is no increase in the type of lesion, then it is if then it is done and you can turn to routine screening. But in any of these, if there is an increase in the lesion or it is persisting also, then the treatment has to be done. So it's just that you are buying some time for about 2 years so that you see if it is a regression, then you can leave her. But if it is persisting or increasing, then you have to treat. So younger patients have higher regression rates, and that is the reason that we are uh, taking this up for the younger women. Next, please. So this is just a pictorial. So if you have satisfactory colposcopy and ECC is negative, then you can go ahead with this, repeating cytology and colposcopy 6 monthly for 2 years. And as I said, if it is negative for 2 years, you can return to routine. If persists or increases, then removal, the excision has to be done. But if there is an unsatisfactory colposcopy right in the beginning and there is a CIN3 kind of lesion, then it has to be treated. Next, please. So women who are more than 25 but they are concerned about future fertility outcomes, here if you put them on observation, then it will be colposcopy and HPV based testing, because above 25 you monitor like that, again 6 monthly intervals, and again if the evaluations remain below CIN2 lesion and sketch, then on two successive occasions, 6 months apart, then subsequent surveillance should occur at 1 year. So here we are talking about HPV based testing, and if they are negative on 3 consecutive annual surveillance tests, then you can put them on long term surveillance. But if it persists or increases, then treatment has to be done. Next, please. So this is from the ASCCP. Again, you see that. So basically, it is not just a histological diagnosis. I'm repeating that. It has what you have to see everything together: the histological diagnosis, the colposcopic picture, the ECC, everything, and then take that decision whether you can put them on observation. So if it is CIN2 specific, then observation is preferred in less than 25 years, acceptable for more than 25 years if there is this concern. But if it is unspecified, then observation is acceptable in less than 25 and treatment is preferred in 25 years. But if it is CIN3 specified, then of course the treatment needs to be done. Next, please. If it's a pregnant woman who is found to have CIN2, colposcopy should not be deferred. Primary aim is to just rule out malignancy. Precancerous lesions are left until 3 months postpartum. But if in your colposcopy you have a doubt that it looks like microinvasive or something, then a biopsy will have to be done. Of course, ECC is contraindicated. And otherwise, for the treatment of CIN2, we wait till 3 months postpartum and then do the treatment. Next, please. As per the FOXY GCPR also, observation may be concerned for women who have not completed childbearing, those who have a discordant histology and LBC prediction of the LCL and I think there is some typing mistake. If there are focal minor changes on colposcopy and HCL on histology, or if it is a recently treated case of HCL, so in those cases, you may just give a period of observation for 6 to 12 months, supervised by an experienced colposcopic, or she is following at a tertiary care center. So it's a very close monitoring that needs to be done, and you have to keep observing the changes that are happening. Next, please. This is the chart from the FOXY 2023, and women who are desirous of pregnancy, young women basically. So if you have the facility of triage with P16 Chi67, then of course it tells you that, you know, if it is positive, then it is it's the colposcopy that will help you decide. Adequate colposcopy you can actually monitor, but if it is inadequate, or if it is the lesion goes higher up with the triage, then it has to be excisional procedure. Not going into further details beyond this. So to summarize, CIN is a local disease, needs local destruction of the tissue. 2 and 3 are true precursors and need treatment based on case characteristics. So you choose according to the case and see the colposcopy findings, the HPV if you have that also, and the ECC, everything together. Watchful expectancy may be offered in women less than 25 years in pregnancy and more than 25 years with concerns for obstetric outcome. And the test of cure that today is best is HPV test. Next, please. So I thank you for this patient hearing. And next, please. There was just a flyer that I had put up for the live workshop that we are planning in July. And I invite you all for the workshop. Thank you.
Yeah, thank you. Thank you, Dr. Nisha. It was an excellent comprehensive presentation on CIN2. Uh, you can explain the flyer meanwhile.
No, no, not to explain. I says because it is a live demonstration on all these procedures. This live workshop on 27th of July at Lucknow, in our department, and there are faculty, national faculty, who will be doing the procedures, and residents, especially residents and gynecs, can see. So I invite you all to attend this and register. Registration is just 1,500.
Yes, that's the best part, that registration is very good. Whoever
Yeah,
is there, please circulate to your residents and everyone.
Yeah,
yeah.
thank you.
Live workshop is really going to be good.
That
And
was a
especially
very wonderful
organizations.
talk from you, Dr. Nisha. And very nicely you have elucidated where are the which are the conditions where we can observe, but still we have to have a very good surveillance on these type of patients.
Yeah, we have one or two questions lying in the chat box, but besides age, I have a question. What determines whether we are going to observe or we are going to intervene a CIN2 patient? You leave behind the age apart. We know that 25 years, we do not have to be very aggressive. We would like to observe 25, more than 25 with fertility concerns. But beyond that, it is what primarily is going to be the determinant of any
So
intervention in CIN2.
now, actually, in our country, if we see that, because we have so much burden of CA cervix already, and we are really wanting that the preventive methods be used. So in general, beyond 30 years, if there is a CIN2 lesion, it needs to be treated. Only if the patient is, quite concerned, she doesn't want to go for it, then you can offer it as an alternate. And but then you have to tell her that it is a very close monitoring that will be required. So that is what it is. I mean, apart from that, as I said, that it is just a histological disease. If you can do the triage, then that will help you if the patient doesn't want. So only when you have the facilities, you can take
Yeah,
those
so yeah,
decisions.
here comes the role of
Yeah.
immunohistochemistry. That's
Yes.
why nowadays with the various tests, Syntec and all available, the dual staining, I mean,
And yeah, another thing I wanted to, on your question only, that because
There
we
were
say
two
now screen,
questions
triage, and treat.
from
So if it is just on the cytology that you have got, and then so if you can offer a triage, and then based on that, that's why colposcopy we were adding again and again. So if it is something like that, so you can do a double check and then take a decision about that. So that we all know, it's only in the community setting that we talk about a screen and treat, that once you see a lesion and you must treat it. So there are options depending upon the facilities that are available, the kind of center that is there, what is the patient's acceptance. So all that will have to be seen together.
Well,
altogether. Dr. Challappan and Dr. Viva have put two questions. One is Dr.
yeah,
Viva has asked
yeah,
that we
this
don't
was
screen below
sorry
25
for, I
years.
mean, interrupting. Ma'am, is it possible that we take up all the questions in the end so that we don't run short of
Oh,
time? And ma'am
I
has
thought these
already
two
very
questions were
elaborate.
good.
Yeah, yeah, sure, sure.
It's okay if you want to take, I'll wait for that. You can do the panel if you wish to.
No, ma'am, two questions. You can just, Dr. Jyoti, you can just put
Yeah,
up.
anyway, Dr. Viva was asking we don't screen below 25 years in our country. So the dilemma of the CIN too.
No, no, that's okay. So I'm, like HIV positive, sometimes you will be doing, although in those cases, treatment is really important. And as such, there is a little, this thing, some guidelines say 21 years. So we are routinely not doing, but if you get a case, then obviously that is what was being discussed. Yeah.
And what type of test they wanted to know, P16, whether it is histopathological diagnosis or cytological diagnosis.
So this is IHC, immunohistochemistry. The P16 test is to be put, and Chi67. This is called dual staining. This will be done on the cytology report. LBC report.
One line. Even in the Asian oncology this one webinar, what we had just 3 days back, there also they were insisting that it's the active this one we have to observe whether it's going for active or anything. But P16 is one of the costly thing. Like for many people, it is very difficult.
Okay.
Once we get it, that is very definitely.
Yeah, that's okay. That's okay. So there are other parameters that we have to see, like the colposcopy, the ECC, and then the patient's wish and everything. So we can take a decision on that.
Yes.
Thank you, ma'am. Thank you, chairpersons and the speakers for the first session. We now move on to the second session, which is case-based discussion on the HPV positive results, and for which I invite our moderators, Professor Dr. Aruna Nigam ma'am and Dr. Rimpi Singla. I invite you both for this session. I will share the screen briefly, and then I invite the panelists for this session. For the panelists, we have with us, we have Dr. Shweta Balani ma'am. Ma'am is Senior Consultant and Unit Head in Sant Parmanand Hospital, Delhi, and she's also the Vice President of the ISCCP. We have with us Dr. Bindiya Gupta. Ma'am is the Professor, Department of Obs and Gynae, UCMS, and she's also a deep interest in gynec oncology. We also have with us Dr. Charanjit Aluwalia ma'am. Ma'am is the unit head histopathology and cytology, VMMC and Safdarjung hospitals with deep interest in oncopathology. And we have with us Dr. Helen Kamai, Professor Jawaharlal Nehru Hospital, Imphal, and in charge of gynec oncology. I welcome you ma'am to start the next session.
Thank you, Annie. I want my screen to be shared. Can I?
Yeah.
Yes, ma'am.
All right, I hope it is visible. So, yeah, thank you, Annie. You have introduced all the panelists, but I want to introduce Dr. Aditi Anand also. She's a senior resident with Dr. Charanjit. She has gathered beautiful this HPV reports and the cases. So, welcome, Dr. Aditi. So this panel is basically meant to enlighten us all that once you have a HPV DNA positive report in your hand, how to handle that. So with this, I invite Dr. Aditi to present the first case.
Good evening, everyone. The first case is of a 42-year-old multiparous female who presented with abnormal uterine bleeding owing to a leiomyoma, and she underwent screening by HPV DNA testing.
Okay. So this is a
ma'am, I request you to put up the questions. Yeah.
Okay. So this is a very common scenario. I'll just have a change in the mood of all. So I'm sorry we had 100 delegates in this meet. We did not expect that we will be flooded with the delegates. So from next time we are going to have an increase. So जहाँ 1 से 100 तक की बात होती है, वहीं 1 से 100 तक HPV की भी बात होती है. So we have 100 type of HPV DNA types, and we are having 100 delegates. So anyways, and we are always concerned with what type. What type is it? A 16, 18, 31, 45, high risk, low risk? So much of confusion all over. So with this background, I would like Dr. Charanjit to solve our few queries. So once there's so many people coming to us, so many labs are coming to us that we are using this test for HPV DNA, we are using that test. So what are the concern really while we should be ordering the HPV DNA testing? What should we see? That lab is using which test and why?
Thank you, Dr. Aruna, and all the members for inviting me here. So, first of all, first is what are the concerns while ordering HPV DNA testing? So, now we know that there are a lot of HPV DNA tests available. So, so many of them are available. So, first of all, the choice of test should be one that has been approved and it has been well researched upon. So out of the approved tests, we have the FDA has approved some tests for primary screening. So first we want to know whether we want a test for primary screening or we want a test for triaging. So FDA has approved several tests has approved a few tests for primary screening. So out of these, the tests are: number one of the tests is Alinity, Alinity M HPV assay by Abbott, then Oncolarity HPV test by BD, then Roche Cobas HPV test, and then we have others as well, like Aptima, which is a messenger RNA based test. So whenever we are ordering a test, if it is a screening, if it is for screening purpose, then we have to see that the test, anything that is used for screening should have a very high sensitivity. So when we are choosing a screening test, it should have good amount of sensitivity, as well as it should be very sensitive, and it should have good amount of specificity as well. Then another concern that we have is cost of the test. These tests are usually expensive, but if you see, and they may not be available everywhere. So if they are available, or if you look at the cost, uh, though the cost is more, but what we gain out of this is there will be less frequent screening. If the test is negative, you screen after 5 years, the patient can be left and rescreened after 5 years. So less frequent screening will be there. Then unnecessary patients visits to the doctor will become less, colposcopies may be avoided. So in the cost, though it is more, it may work out less in the long run. So the another concern that we have to look at is, since they have a very high sensitivity, these are very sensitive tests, even if very little amount of DNA is present in the sample, the test will become positive, though the patient is not having any clinically significant disease. So in such situations, the patient may become very anxious, and we have to see to that. Then false negatives may also be there. For example, if we perform the test at the wrong time, like in the window period, so that is when a person becomes HPV positive and when the test comes positive. So that is the time, that is the window period that the person gets, the individual gets the infection, and the time when the test comes positive. And this is around 4 weeks, but this is very variable. It can be from 3 weeks to a few months. So if the test is performed during this period, or the sample has not been transported properly, so, or has not been dealt with properly, the test may come out negative. So that would become a false negative, and this offers a false sense of security to the patient. So by keeping all these things in mind, and then another important thing that we were discussing was the age of the patient. For usually WHO says for women less than 30 years, PAP is a better test to do, because in less than 30 years, HPV infection is very common, and this infection usually regresses, or it is cleared by the immune system. So again, doing HPV test, doing a PAP test would be a better idea. So by taking all these things into consideration, one should always order for a test which meets our expenses, of course, but which has been approved by all standards. So
So I
that
think the message is clear. The test should be validated, which we
validated
are
and
using as a primary HPV DNA
yes,
screening test.
screening,
So
yes.
now the question comes, if it is coming many a times, we get HR HPV positive, and sometimes few numbers are written and then written others. What do we mean by that? And what is most important once we are having a report of HR HPV?
Okay, so when we have, if you look at the report now, I told you that the methods, about the methods. So the tests, like for example, Cobas HPV test, which we use in our laboratory. So what will the report tell you? The first part of the report is, the report will tell you this test looks for 14 high risk HPV types. So if any of these 14 high risk HPV types is positive, the result will be HPV test result will be positive. Next is these many of these FDA approved tests, they also do partial genotyping. That is, they look for which specific viral type is present in the sample. For example, is it HPV 16 or HPV 18? So the second part of the report, which will be shown, will tell you whether it is HPV 16 that is positive, whether it is HPV 18 that is positive, or it is the other 12 high risk HPV types together. If any of them is positive, that will also be reflected in the report. So that is the
So
how.
Dr. Bin, yeah. So I would like to Dr. Bindya, is there any advantage of knowing besides 16, 18 that this is 31 positive, this is 45 positive? Are we going to get any advantage of knowing just that it is 16, beyond 16-18, you get more HR-HPV numbers. So
Yeah.
our management is going to differ in those cases?
So, Dr. Aruna, thanks for the question. So, 16, 18, we say them particularly because they are the ones which are the most notorious and they're known for causing the squamous cell cancers and the adenocarcinoma also. But we should not ignore the other high risk types also, for instance, like 45, 58, and other high risk types also, because they're also they're also commonly associated with like adenocarcinoma. So, they should not be ignored. But yes, when you have the intermediate risk types, so it is not necessary to do colposcopy or intervene as seriously as you could do for a 16, 18, but you have to be cautious. You can triage with other modalities like what ma'am said, a cytology, or we can do maybe we can keep them under close follow up, or if suppose the patient is non-compliant, then we can do a colposcopy. So we have to be careful also with the other high risk types also, if we are dealing with the non 16, 18.
Okay. So
And
let
also
me.
to this, I will also like to add to the armamentarium, and I will just open this. Lately, I just attended Dr. Nija Batla's and Dr. Seema Singhal lecture. They just presented their interim IHPV results, and which they have validated some indigenous HPV
Yes.
tests in AIMS Delhi. So there, this they have validated TrueNat, which is by MolBio, even PathoDetect by MyLab, and it is one is detecting HPV 7 HPV types, and one PathoDetect 14, which is also by MyLab, which is detecting the 14 high risk HPV types. So they have found good results and they have found excellent validation with these. So they are also very potential. And what is the advantage of this TrueNat? As Dr. Charanjit will also agree that these are like on the spot tests. You know, they can just treat and you can test and treat at the same go. Like what we had an expert. So point of care testing is very good with these platforms. So these have been indigenous tests have been also been validated by AIMS Delhi.
And most probably we are going to have a lesser cost of these tests. So currently we are
Exactly.
having a minimum cost of 1100 rupees by many of the labs, but these are expected to be ranging in between 600 to 800, hope so, in
And
near future.
the one test which is point of care test which is available, which gives a report in 1 hour, the one cartridge it costs more than 3,000 rupees for one test. It is a Cepheid Gene Expert.
Yeah, expert. Yeah,
So
gene
yeah,
expert. That
Gene
is
Expert it
validated by
costs
WHO.
3,000 per cartridge.
Yeah. So that is the thing. The main cost is of that cartridge. The machine is for around the cartridge cost. So what happens is, just to tell, Dr. Charanjit, if you can tell that how does this it work? Actually, the cartridge work by changing the colors. If you can explain in 2 minutes, this point of care testing.
In this point of care testing, the principle is the same. If we have a probe against a particular part of HPV virus, say it is against the L1 part of the virus or against the E6, E7 genes of the virus, the probe will attach to the virus. Once the two attach together, there will be once the if the virus is there in the sample, the probe and the virus will combine, they will hybridize, and the probe is linked to some sort of, whether it's a fluorescent reagent or some sort of reagent, which is going to produce a signal which is picked up. So, picked up, just telling us that the result is positive, that the virus is present in the sample, oncogenic virus is present.
So, okay. Dr.
So,
Shweta,
all
now.
this, okay, yes.
So, Dr. Shweta, now this case, who is a AUBL, in with abnormal uterine bleeding, and somebody does the screening by HPV DNA testing. So now what it came out to be HPV 18 positive. How do you counsel and what next?
So, Dr. Aruna, she is HPV positive, 42 years. First thing is very important to tell her that this is a viral infection which is in her cervix, and in maximum number of people this will get shed off and clear by her own immunity in another 1 or 2 years. But yes, because this is a virus which is associated with cervical cancer, and the test we have done is a screening test, we would like to go in for a diagnostic test for you. And that is what a patient needs to know, that yes, I have an infection doesn't mean that I have a cancer. So this is very important. And the next thing I will really emphasize that yes, the 18 is a high risk one and you will need a colposcopy. And side by side, I will definitely do a reflex cytology also in the same sample.
Well, so in cytology, it came out to be Excel, and I think biopsy came out to be CIN2. So what next? Now AUBL at 42 years, CIN2 lesion. What next? I think Dr. Helen is not there, so Dr. Sweta will continue with this.
So, see, if the patient AUB cannot be treated with medical and she has a fibroid which needs to be tackled with, then definitely hysterectomy should be done for this patient because it will sort of treat both the things together, but with the emphasis that she will require a follow up throughout her life, say for first 20 years at least after this has been even hysterectomized, if she is hysterectomized then also.
Okay,
That is
so
a
that
very
is very
beautiful
important.
message.
Follow-up is
That's a
very
beautiful
important for next 20 years in cases of CIN2 lesions. So I would just like to go back to the pictures which are there of histopathology. For the benefit of all, I would request our senior resident to kindly elaborate on the pap smear findings and the CIN2 lesion, which is very important. You must know this.
All right. So this is liquid-based cytology from the patient, which is showing presence of multiple parabasal cells. So these parabasal cells have characteristic high NC ratio, and this particular cluster in the inset shows presence of cells which have irregular nuclear membrane and definitely hyperchromatic nucleus. And as compared to the other cells in the background, it is in stark contrast, the high NC ratio and the hyperchromatic nucleus and nuclear membrane irregularity. So this gives us a diagnosis of high-grade squamous intraepithelial lesion in the patient. And this was followed up by colposcopy, and the colposcopic image is in the next slide. So this is the ectocervix, the comprising of the various comprising of squamous, stratified squamous epithelium. Now, if we look closely around the basement membrane, there is presence of cells resembling parabasal and basal cells, and these cells have maturation arrest. So these cells have high NC ratio and hyperchromatic nuclei and nuclear membrane irregularity. However, it is limited to the lower two-thirds of the thickness of the lining epithelium, and it is confined above the basement membrane, not invading into the stroma. So this makes it a cervical intraepithelial neoplasm, and since the thickness is less than two-thirds, then it becomes CIN2 lesion.
Thank you, Aditi. It was a very nice description. And for all of you who are attending, I'll tell you in our course also, we make you understand from the basics till the advanced. So pathology, histopathology, pap smear, everything is being taught to you very nicely. So you must join us ISCCP colposcopy training course. So with this, I would like Dr. Rinpui to continue with further questions.
Yeah, Dr. Aditi, I think we should move on to the next case. So here, Dr. Shweta has very well said that she is 42 years old. She's already suffering from menorrhagia because of fibroid, and she has got CIN2 lesion. Yes, hysterectomy can be offered in her case. And the perfect point was that she requires the surveillance for 20 years. That is very important because she's going to undergo hysterectomy she's also harboring a CIN2 lesion. So this is just to summarize our own guideline on this. It is available on the website. And Dr. Aditi, just present the second case before we move on.
Ma'am, the second case is of a 35-year-old female who presented with abnormal uterine bleeding along with discharge per vagina. And she also underwent screening by HPV testing and came out to be positive for HPV others. So these HPV others are besides the two high risk 16 and 18. These are the 12 other high risk HPVs.
So Dr. Shweta has put up her perspective of counseling very well. Anybody wants to add? Because ma'am has already highlighted that, yes, you need to counsel that it is a viral infection. So Dr. Shweta, what will be the next step in this? Now, this one is not having 16, 18.
Yes, so counseling Counseling will be almost the same, that you have to tell that yes, the virus is positive, which is just a screening test, and most probably you will clear this infection with your own immunity. But here with the other high risk, I will definitely ask for a reflex cytology or triage this patient by some other mode of screening.
Very well. So this is a WHO guideline. I would like Dr. Shweta to highlight this as you have opted for cytology for triaging. So I want
Yes.
you to highlight this for the benefit of our participants.
Yes. So suppose I'm doing a triage and the patient is the cytology is negative, then this patient can be put on a follow up every 1 or 2 years, and especially 1 year if the patient is HIV positive. And if there is a cytology report anything more than ascus, then yes, she will require a colposcopy, and the further management will depend upon the findings which we get on the colposcopy.
So very well, we did her pap smear. Aditi, would you teach us what this pap smear says?
Yes, ma'am. This is again liquid-based cytology of the patient. So highlighted by the red arrow is a cell, an intermediate cell and compared to the cell on its right is a normal looking intermediate cell. The difference between the two is the difference in the size of the nucleus of both the cells. The one highlighted by the red arrow shows increase in nucleus size, which is a characteristic feature of LCIL. And the cell highlighted by the green arrow is a cell with hyperchromatic nuclei. It has some degree of nuclear membrane irregularity and the characteristic perinuclear clearing, which corresponds to coilocytic change, which is a viral cytopathic effect. So case was reported out as a case of low-grade squamous intraepithelial lesion.
So this patient is 35 years old, positive for other high-risk HPV DNA, and she's having L-serine cytology. So what next? Dr. Bindia, you want to take up this question?
Dr. Rimpi, I
Yeah.
want to highlight this point. Like this patient is other high risk positive, but there are
Yeah.
certain labs which will tell you about, say, she's HPV 45. So it is very important to see and follow up this patient if the same virus comes positive. Suppose after 2 years she again has a HPV 45 positive, then this patient, because of the persistence of same kind of a virus, is more prone for a CIN or a cervical cancer. Meaning to say that the persistence of same strain makes it a high risk for cervical cancer or the pre-invasive lesion.
Very well taken, Dr. Shweta. Ma'am is actually talking about the extended genotyping. So here we come to know the details of other virus also. And COBAS is giving us two things, HPV 16, 18 and the rest of the 12 as a batch.
The
So if
partial
you have
genotype.
extended genotyping, then you get to know the individual types. And yes, if it is a persistence is type specific or it is a type different, so there is a little bit of risk of persistence in case it is same type. So thank you, Dr. Shweta. That's a wonderful point. And in this case, the PAP is LZIL and other high risk positive. So Dr. Bindia, what would you like to do next?
So yeah, as we discussed in the algorithm, as beautifully explained by Dr. Shweta, like when it is anything more than ascus, we have to do a colposcopy. So now here she's other high-risk HPV positive with LCIL. So we'll take her up for colposcopy. And we've done the triage, which is LCIL. So we'll be going for colposcopy.
Any role of dual staining here for managing this case, Dr. Charanji?
Yeah,
Would you just
so
teach us about dual stain also?
okay.
It's a new thing come up.
Dual stain means we are doing two IHC markers on the same sample. So the dual staining, two IHC markers, immunohistochemistry markers or immunocytochemistry markers that we use are P16 and Ki67. Now P16, we know it is a marker that tells us that the cell, if this P16 is expressed in the cytoplasm of the cervical epithelial cells, and Ki67 will be expressed in the nucleus of the cells. Now, P16 tells us that high risk HPV virus is protein is found in the cytoplasm, and Ki67 tells us that now these cells are multiplying very fast. It is a cell proliferation marker. Now, if you look at any cells in our normal pap smear, the two of them, P16 and Ki67, will never be expressed together. They are mutually exclusive because P16 expression will be found only when the cell is is infected by high-risk HPV virus. So now we have this dual staining kit. One of the kits approved by FDA is called Syntec Plus, and in this kit we can take the LBC sample, and on the LBC sample you can put immunohistochemistry for both these P16 and Ki67. The Ki67, if the cell has HPV infection, the nucleus of the cell is going to stain red because of high Ki67 or high, because the cell is proliferating fast, and the cytoplasm of the cell, because it is containing P16, which tells us that it is infected with HPV, it is going to stain brown in color. And if you have even one or more of these dual stain cells, we say that the test is positive. And now these are the people who are likely to progress. So in a way you have triage. These are the people who are likely to progress or likely to have a progressive lesion or likely to progress to cervical cancer. So they need more, a treatment or more aggressive follow-up.
Thank you, Dr. Charanjit. Dr. Bindya, Dr. Shweta, you want to give your comments on the role of genotyping, specifically in which cases you should be employing genotyping? Is it like all of the HPV 16, 18, any HPV DNA, or some particular cases it will help? I request everyone please not to annotate over the screen. Thank you.
Yeah, there's
It
been a
has
lot of
really become very
annotation.
colorful. Thank you, but don't do it further.
Yeah, so basically, yes, as Dr. Charanjit mentioned, dual staining has a very important role. And if it is positive for P16 and Ki67, it not only suggests infection, it suggests the persistence and that it is causing those changes. So we need to do a colposcopy, and we need to do some biopsy and accordingly manage the patient. See, partial genotype for a country like ours, if we give a general statement, don't go by numbers of the other genotypes. It's very important to emphasize on 16 and 18 because they are the ones which are responsible for the 90 to 95% of the cases are 16, 18, which are going to cause cervical cancer. Why should we spend our resources on the other 5%, especially in a country like ours where 16, 18 only doesn't get managed properly? So if you're sitting in a corporate, if you're sitting in a very hi-fi hospital, and if you have this facility of 45, 58, 33 all available, then as Dr. Shweta mentioned, that look for persistence, triage those patients and accordingly manage. Otherwise, for us as a general consensus, just partial genotype for 16, 18 is more than enough. If 16, 18 is positive, go for colposcopy, go for biopsy, and go for treatment accordingly. And if it is other high risk types, then just go for triaging, and accordingly you can follow up depending on your triage test. So that is my take on management with genotypes as of now in the current scenario.
Yeah, that is very important and relevant also, that how to use your resources, because there are a lot many questions in the chat box that this test is not available with us, that test is not. So we have to use our resources and whatever test available to us, and we have to, guidelines are there to guide us, and we have to make our protocols according to the guidelines so that we can sustain and give the best to our patients. So if P16 is not available, no problem. You can go for a colposcopy in this case, or you can try it with some other method. It's not necessary that you are going for a dual staining. By the way, somebody has asked, what is the cost of the dual staining?
So very expensive.
Madam will say, Dr.
Not
Charanjit.
even freely available. So basically, the main motto of this particular slide is that you are not going to, even if it is available somewhere, so you're not going to employ it anywhere. If it is 16, 18 positive, or if it is a high grade cytology, then it is recommended not to be used. Please go for colposcopy if your patient is harboring 16, 18 positive, or she is already having a high grade lesion of cytology. It is not meant for that. So it is basically for those setups where colposcopy is more, difficult to access than this all other things. So in our
Yeah,
setup, colposcopy is, more accessible than this dual stain, right?
yeah,
So
that's
for our
right. But
patient,
still,
we went
for
ahead
the
with
Yeah,
knowledge
I
of
think we agree
everyone, Dr.
on the
Charanjit, what is
same.
the
Yeah,
cost of this?
yeah, cost, as Dr. Rimpi said, it is quite expensive. I'll just give you an example.
Yes.
I am in a government setup. So we have P16, we have Ki67, we have host of IHC markers. And but from what I come to know, so we are doing free of cost for the patients. Routinely, we do P16, Ki67. But in private labs, one marker, one IHC marker can cause as much ranging from 2000 to 3000. And if it is very expensive IHC, the cost goes much beyond that. So they are,
Yes,
yes.
very rightly. So any IHC marker, whether you are going on an endometrial biopsy sample or you are going on a pap smear sample, it will cost minimum 1800 rupees,
Yes.
and then it can extend according to the IHC
Number of
marker which you are ordering. So
Ordered, yes.
minimum cost is 1800 for a single marker,
Single.
So it is not easy to get this.
Our patient underwent colposcopy and we did a biopsy also. So biopsy showed CIN1. So basically now our patient is having other high-risk HPV DNA positive. She had LCL and now she has got CIN1 lesion. So what would you like to do next?
So with this report, with this background of intermediate, high risk, and low grade cytology, I think observation is the best for CIN1 because it's better to see. We should only treat persistent CIN1s if it is persisting after 1 year. So a low grade, low grade smears with low grade HPV and low grade biopsy, they're all concordant. So it's better that we observe this patient. However, we have to see that the patient is compliant. That's very important. If you're sitting and if you think that the patient will go back to the village and never return back, so if, in that case, you can offer some treatment like an ablate, depending on the transformation zone. You can do cryo or thermal. However, if it is she's compliant to your follow-up, so then you can just observe the patient and follow her up after 1 year.
Perfect, Dr. Bindia. I really, really appreciate that you highlighted that we are dealing with our Indian population. So if we know that she might not turn back, so it is better to go for ablation if it is amenable to ablation. Thank you so much for this point. This is not there in the guidelines, but this is definitely from our practical experience. The patient really don't turn up back.
Yes.
So I don't think that we have much time left.
We don't
so
have.
should we stop here, Dr. Aruna?
Yeah,
ma'am?
yeah, please, we can, because we promised for 70 minutes only. So it is 70 minutes. So you can take any questions if they are there in the chat box, and then we can call it a day.
So let me open my chat box.
Somebody questioned that, can't we use P16 in the case 1? And if the patient wants to avoid surgery, then put her on Mirena, Ulipristal if patient is eligible, and put her on regular follow-up for CIN2.
My panelists, chairpersons.
Yeah, so I think if she is not wanting hysterectomy, so if she is amenable, if the fibroid, it depends on the fibroid also, not the size and the location and the symptoms. So if it is, you're not offering surgery and you're wanting conservative, then you have to put her on follow-up, or you treat CIN2. You can even do ablation, or you can do a leap depending on your colposcopy findings. And if required, I think she was 42. So 42 CIN2, I would like to offer some treatment rather than, giving her observation. So we can treat the CIN2. You can put her Mirena if it's a very small fibroid, and you can monitor her. That's also an option.
So all depends upon the compliance of the patient. If she can come back, we can give a good counseling to this patient, I think. And we can do colposcopy and simultaneously ablation or excision therapy, which is available with us. We can do if provided that your AUBL is treatable by a conservative management. This you must think of.
True. One can tailor after the ultrasound report and the other findings.
Yeah. So I think all questions are covered, Dr. Rimpi.
Yeah, yes. So just before I end, I want all my panelists, if you, Aruna ma'am permits me 1 minute, just
Yeah,
one
please.
carry home message.
Yeah. Good evening, Dr. Aruna Nigam. I'm Dr. Leela this side.
Yes, ma'am.
Yes,
Very
madam.
welcome, Leela ma'am. Thank you for joining. I know you are out of country.
Yeah. No, I'm
Thank you so
listening.
much, ma'am, for
No, just
joining.
actually, I've written that question. Actually, in this case, where it is HPV 18 positive, Dr. Sweta Balani wanted to do reflex cytology. So, what is there a need to do reflex cytology when HPV 16 or 18 is positive? Because anyway, they need colposcopy. Whereas in the other scenario where it is a other high risk HPV, definitely I feel reflex cytology can be considered. But in this particular first case, she mentioned that she wants to do reflex cytology. So I just want to know what is the need to do a reflex cytology when definitely she needs a colposcopy.
Yeah, definitely, Dr. Leela, colposcopy is the answer. But looking at we have the sample ready for the patient, matlab, just to have a second hand knowledge of what was the cytology report when the sample is there in the lab. That was the idea. But yes, colposcopy is the answer for that.
Another point, Dr.
And
Shweta, in case if suppose you're, if it will help in the follow-up also. Suppose in the follow-up you go somewhere where HPV testing is not available. So we have hands-on information that what was our previous cytology. That was also one of the reasons I thought we can offer a cytology at that point of time.
And this guidelines also, I think, that supports that a reflex cytology should be offered to all HPV positive regardless of the genotype.
Ma'am, actually,
okay.
this comes from ASCCP, where they have one provision of giving expedited treatment. I mean, expedited treatment is if she is positive for 16-18, and if she is having cytology also high grade, then you can straight away go for the treatment. I mean, it carries a very high risk of underlying CIN3. I mean, direct treatment even without colposcopy. So here, ASCCP 2019 guidelines, we just wanted to highlight that, I mean, this option is also there just for the knowledge of everyone. But yes, if you look at the WHO
Colposcopy.
guidelines and if you look at our own Indian guidelines, yes,
Dr.
we can
Rimpi,
straight away go for
sorry,
colposcopy.
this is going to end because
Yeah, yeah. Okay, okay.
yeah. So I
Let me
think
also add one point. Can I? I think
yes,
I
ma'am,
totally
yes,
agree
ma'am.
with
Hi,
Dr.
ma'am.
Yes,
Two
Leela.
ma'am.
minutes, ma'am,
Yes.
it's going to
Hi.
end.
Yeah, just because I agree with Dr. Leela, because 25% of the cytology, even if you do LBC or conventional, whatever you do, it may still miss the abnormality. So you have to do a colposcopy. There is no way out. So you
Yes.
have to see
Yes,
the
it
changes in the colposcopy. So you are increasing the cost by ordering reflex, triaging method by LBC. Just do HPV and then go for colposcopy if it is 18 positive. I totally agree with Dr. Leela there.
Right, ma'am. Absolutely. Thank you. Thank you, Vijay ma'am. Thank you for joining and thank you for your comments also. Thank you.
Bye.
Yeah,
So, any,
one last comment. I know it's not comment, suggestion, because it's a colposcopy society. You have done colposcopy for both the patients, but the colposcopy images are not put in the slides. So
yeah,
that's the only suggestion, I think. If
yeah,
colposcopy
yeah.
is done, it is better to put those images also, because that is going to enhance our knowledge.
Well taken, Dr. Leela, but that has been purposely not included
Ma'am,
because we
yeah.
actually wanted to focus on only on the HPV DNA testing. Although I know the discussion can go anywhere haywire, but today the purpose was only the HPV DNA testing, which we have left in the last session. So that's what we wanted to cover. But every time we will try to cover the colposcopic images according to the topic allotted.
Time was also less. Otherwise, we had put up these images in this
Yeah.
case also and in this next case also, which Dr. Shweta was going to describe.
Yeah.
Sorry for
Yeah.
that, ma'am.
Good webinar,
No.
Arna, good webinar.
Yeah.
Informative. Charanjit, as usual, excellent.
Thank you,
And
ma'am. Thank you.
Molecular, yeah. Every time you keep on adding.
and we are
Thank you
so
so much.
happy to tell that we have 100 all the time, and we had a request on the group that we should be increasing. So from next time we are going to increase the
You
group
should do it
size.
unlimited.
Yes, definitely. So treasurers are ready, so we are going to do this.
Yeah, go ahead.
Okay.
So once
So
again, I would like to announce regarding the credit point system. If somebody has left, please do the activities being a ISCC member under the banner of ISCP, your public forum, your CME, your workshop, your efforts matter. So you will be credited, you will be accredited for that. And we want that we should be recognizing your effort. So go back to our website and see all those information which are there available regarding all this accreditation and many more informations are available. So we want that you should be visiting the website, which is all yours. And the suggestions are always welcome.
yeah.
So with this, Dr. MP, please.
Thank you. Thank you very much, ma'am. And I would like Dr. Bindia to deliver the vote of thanks to our esteemed faculty. Thank you, everyone, for joining.
So thank you very much, Dr. Rimpi, for taking the initiative for organizing this chapter of the webinar. And at the same time, I would like to thank all the esteemed faculty for sparing their valuable time and giving such expert comments. And so, Dr. Nisha, thank you for a very, very informative lecture. It was very well
Excellent.
taken, an excellent lecture, very well appreciated. I would like to thank all the esteemed panelists and the moderators. So all of us are there. So thank you very much, and thank you, Ayan, for the very well coordination for the webinar. And so thank you, Chairperson Dr. Mamta, Dr. Jyoti. We missed Dr. Sekhon because of the 100 full webinar, Dr. Sekhon could not join. So I sincerely apologize for that. And next time we will ensure that this doesn't happen. So with this, I will like to take leave, and we will conclude the webinar. For the next webinar, 7th of July, please join. It's a very, very interesting topic. We'll be discussing about AI and its role in colposcopy, cervical cancer screening, and a lot of devices will be discussed. So please do log in next time also. And the same 7th of July, 70 minutes, 7 p.m. So thank you very much for attending this webinar and such an overwhelming response. Thank you very much.
One last request, Dr. Jyoti, Dr. Shweta, and please, can you just turn on your video? I just wanted to have a capture. Dr. Jyoti, Dr. Aditi, Dr. Jyoti.
Everybody, please turn on your
You can
cameras.
just turn on the camera. I can just click a
And
pic and
whosoever
post it.
is there can
Yeah,
please.
whosoever it is. Dr. Parneet, I can see you. Yeah. Thank you, everyone. Thank you so much.
Thank you. Thank you so much.
Thank you. Thank you so much.
I
Thank you,
turned
Dr.
on now.
Rimpi. Thank you so much.
I'll
Now
click
I'll end the
again,
meeting.
Dr. Jyoti, for you.
Yeah.
Thank you.
Good night.
Thank you.
Good
Thank you.
night and thank
Good night,
you.
everyone. Good
Thank
night.
you.
Thank you very
Enjoyed
much.
meeting
Bye.
everyone after a long time.
Same here, Dr. Nisha. We'll
Same
see you
here.
soon next month.
Yes,
Bye.
sure.
Yeah. Okay. Bye-bye.
Bye.